seriously when you give the metformin. So we should be very much cautious regarding use of the metformin in acute asthma. And we should do the blood sugar profile, control the blood sugar level by preferably giving the insulin in diabetes in asthma. So thank you very much for your questions, sir.
Dr. Muhammad for the presentation.
Honorable Chairperson of this session, Mr. Reporter, my learned audience, Assalamu alaikum. Now I welcome you to my presentation. The paper of my presentation is Asthma in Pregnancy and Overview. As you know, asthma is a chronic inflammatory disorder causing hyperresponsiveness of the airways to certain stimuli, resulting in recurrent variable airflow limitation. That is partly reversible, presenting as wheezing, breathlessness, distractedness, and coughing. Asthma is a serious health problem worldwide. Its prevalence has increased in the past 2 decades. Approximately 8% of pregnant women reported current asthma. It is the most common chronic condition in pregnancy. Now, the changes in respiratory function during pregnancy. Normal pregnancy is associated with 20% increase in oxygen consumption, 15% increase in the maternal metabolic rate. And this extra demand is achieved by a 40 to 50% increase in resting minute ventilation, resulting mainly from a rise in tidal volume rather than respiratory rate. This hyperventilation causes percentage of oxygen in arterial blood to increase, percentage of carbon dioxide in arterial blood to fall, with a compensatory fall in serum bicarbonate level to 80 to 22 millimole per liter. A mild respiratory alkalosis is therefore normal in pregnancy. 75% of women experience a subjective feeling of breathlessness during pregnancy. In late pregnancy, the diaphragmatic elevation caused by the enlarging uterus leads to a decrease in functional residual capacity. No change in peak expected flow rate or FEV1 in pregnancy. Decreased functional residual capacity may exacerbate hypoxemia because of premature airway closure when acute asthma complicates pregnancy. Now, what are the physical factors affecting asthma in pregnancy? Increase in free cortisol level may protect against inflammatory triggers. Increase in progesterone may improve airway responsiveness. Increase in prostaglandin F2 alpha may promote airway constriction. Placental 11-beta hydroxysteroid dehydrogenase type 2 decreased activity is associated with an increase in placental cortisol concentration and low birth weight. Placental gene expression of inflammatory cytokines may promote low birth weight. Modification of the cell-mediated immunity may influence maternal response to infection and inflammation. Now, the effects of pregnancy on asthma. The course of asthma in pregnancy in an individual woman is largely unpredictable. Women with mild disease are unlikely to experience problems, whereas those with severe asthma are at greater risk of deterioration, particularly late in pregnancy. Asthma may improve during pregnancy due to progesterone-mediated bronchodilation and increased serum cortisol levels. Asthma may deteriorate during pregnancy due to increased stress and increased gastroesophageal reflux. Many asthmatic patients experience worsening of symptoms during pregnancy because they stop or reduce medication due to fears about its safety. During pregnancy, the severity of asthma remains stable in a third of women, worsens in another third, and improves in the remaining third. This is popularly known as rule of 1/3. Now, the effect of asthma on pregnancy. In most women, asthma has no effect upon outcome of pregnancy. Severe, poorly controlled asthma may have an adverse effect on the fetal outcome as a result of chronic or intermittent maternal hypoxemia. Increased risk of premature labor, low birth weight, higher rates of pregnancy-induced hypertension, preeclampsia, and cesarean section. Increased incidence of transient tachypnea of the newborn, neonatal hypoglycemia, neonatal seizures, admission to the neonatal intensive care units in the babies of asthmatic women. Now, what are the special considerations to be kept in mind in pregnant women with asthma? Ensure optimal asthma control throughout pregnancy, manage asthma exacerbation aggressively, avoid delay in diagnosis and treatment, assess medication needs and response to therapy frequently, ensure adequate patient education and acquisition of self-management skills, treat rhinitis, gastric reflux and other comorbidities adequately, encourage smoking cessation, assess pulmonary function with a spirometry at least monthly, offer a multidisciplinary team approach, be aware of the risks of preeclampsia and intrauterine growth retardation. Now, what are the main differential diagnoses in pregnant women with dyspnea? Asthma, physiological dyspnea of pregnancy, pulmonary embolism, pulmonary edema, peripartum cardiomyopathy, amniotic fluid embolism. Now, when you know asthma in pregnancy, all patients should be educated regarding the relationship between asthma and pregnancy. And they should be taught about self-treatment, inhaler techniques, adherence to medication, control of potential environmental triggers, appropriate management of common coexisting conditions such as rhinitis, sinusitis, gastroesophageal reflux. Women who smoke must be informed of the potential adverse effects of smoking on the fetus, and they should be strongly encouraged to quit smoking. Now, the asthma control in pregnant women. Frequency symptom, it is less than 2 days per week in well-controlled asthma, more than 2 days per week when asthma not well-controlled, and throughout the day when poorly controlled asthma. Frequency of night-time happening 2 or less than 2 times per month, in well-controlled asthma, 1 to 3 times per week when asthma not well-controlled, and 4 or more than 4 times per week when very poorly controlled asthma. Interference with normal activity, it is none when well-controlled asthma, some when asthma not well-controlled, and extreme when asthma is poorly controlled. Use of short-acting beta agonist for central control 2 or less than 2 days per week in well-controlled asthma, more than 2 days per week when asthma not well-controlled, and several times per day when asthma is poorly controlled. Epipen or P-acetylcholine more than 80% when asthma is controlled, 60 to 80% when asthma is not well controlled, and less than 60% when asthma is poorly controlled. And the number of exacerbation requiring use of systemic corticosteroid 0 to 1 in first 12 months when asthma is well controlled, 2 or more than 2 in the first 12 months when asthma is not well controlled, and 2 or more than 2 in past 12 months. Now, the FDA pregnancy risk category 1, control studies show no risks. Adequate well-controlled studies in pregnant women have failed to demonstrate a risk to the fetus in any trimester of pregnancy. Category B, no evidence of risks in humans. Adequate well-controlled studies in pregnant women have not shown increased risk of fetal abnormalities despite adverse findings in animals or in the absence of adequate human studies. Animal studies show no fetal risk, and chance of fetal harm is remote but remains a possibility. Category C includes the interpretation high risks cannot be ruled out. Adequate well-controlled human studies are lacking, and animal studies have shown a risk to the fetus are lacking as well. And there is a chance of fetal harm if the drug is administered during pregnancy, but the potential benefits may outweigh the potential risks. And category D, there is positive evidence of risks established in humans or investigational post-marketing data have demonstrated fetal risks. Nevertheless, potential benefits from the use of the drug may outweigh the potential risks. And category X, the drug is contraindicated in pregnancy, started in animals or humans, or investigational or post-marketing reports have demonstrated positive evidence of fetal abnormalities or risks that clearly outweighs any problems or possible benefits to the patient. Now, the FDA pregnancy risk category, the status rating of asthma medication. Salbutamol, the risk category is C, and the magnitude of teratogenic risk undetermined, and data is limited. Levosalbutamol category, risk category is C, and there is no available data. Salmeterol, risk category is C, and the magnitude of teratogenic risk is undetermined.